Good morning, everyone. Welcome back to Upload Radiology case series. So today we'll be seeing a 45-year-old lady who came with rapid increase in neck swelling. Thyroid function tests were normal. This is the transverse and longitudinal view of the ultrasound. Here we are able to see there is a diffuse enlargement of the thyroid gland, which is markedly homogeneously hypoechoic, and there is posterior acoustic enhancement, which is seen here. The right parotid gland showed a well-defined hypoechoic lesion in the superficial lobe of the parotid gland, which was again showing posterior acoustic enhancement. Bilateral cervical lymph nodes were enlarged with loss of fatty ilam. It was heterogeneously hypoechoic and it was mimicking the echo texture of the thyroid gland, which is seen here. This is a plain CT neck. There was diffuse enlargement of the thyroid gland, which was seen here, which was homogeneous in nature with multiple enlarged bilateral cervical lymph nodes involving the submental, submandibular groups, level 2, level 3, level 4, and level 5. There is a right parotid hyperdense mass lesion which was seen. This is a right parotid mass. So to summarize the imaging findings, there was diffuse enlargement of thyroid, which was homogeneous in nature. There was no focal mass lesion as such, which was seen in thyroid. There was a right parotid mass lesion, which likely can be a lymph nodal mass, and there was diffuse bilateral cervical lymphadenopathy. So the differential diagnosis in such a setting will be primary thyroid lymphoma, and the other possibility would be thyroid malignancy, especially papillary carcinoma with lymph nodal metastasis. So coming to primary thyroid, it is a very rare tumor. It constitutes less than 2% of all malignant thyroid tumors. The management differs from primary thyroid lymphoma differs from that of the other thyroid neoplasms because it's often curable without surgery. So the suspicion of primary thyroid lymphoma has to be raised by the radiologist or the cytologist, and as this will result in an early diagnosis and prompt treatment of this potentially curable thyroid malignancy. The most important risk factor for PTL is Hashimoto's thyroiditis, which is a precursor or is a bet for a primary thyroid lymphoma to occur. Primary thyroid lymphoma can be classified as either diffuse or non-diffuse type. The non-diffuse type is further subdivided into nodular or a mixed pattern where we see nodular lesions as well as the diffuse enlargement of the thyroid. Ultrasound findings, quick recollection of when we call these things. We call something as a goiter or thyromegaly when the craniocaudal length is more than 6 cm or the anteroposterior diameter of the lobe is more than 2 cm. Markedly hypoechoic is when the echo texture is less than that of the strap muscles. Isoechoic when it is equal to thyroid gland. Hypoechoic when it is between the echo texture of the strap muscles and the thyroid gland. Hyperechoic when it is more than that of the thyroid gland. Macrocalcification and microcalcification when the posterior acoustic shadowing is present and the size of the lesion is more than 1 mm. Microcalcification if the size of lesion is less than 1 mm without posterior acoustic shadowing. Lymphadenopathy if the short axis diameter is more than or equal to 5 mm, abscess of hilum, heterogeneous ecotexture, chaotic vascularity, or if you see cystic or calcific foci within it. Primary thyroid lymphomas can be of two types, diffuse or non-diffuse type. In the diffuse type, which we saw earlier, shows usually a goiterous kind of an enlargement, homogeneous or heterogeneous ecotexture, a marked hypoechogenicity. There's a posterior acoustic enhancement which is seen in spite of the tissue being solid, which is a very useful discriminating factor between primary thyroid lymphoma and Hashimoto's thyroiditis. Calcification is usually rare. It's not seen in either the diffuse or non-diffuse type. But occasionally we can see macrocalcification or microcalcification. Just like any other lymphoma, calcification by dictum should not be seen in a primary thyroid lymphoma. Cervical lymphadenopathy is also seen in primary thyroid lymphoma. Non-diffuse type, it presents with all the findings of the diffuse type, plus there is multifocal lesions which are seen in the thyroid gland. There is increased vascularity and occasionally there can be calcification. Coming to the differential diagnosis, the most important differential diagnosis is between Hashimoto's thyroiditis and primary thyroid lymphoma, which at times can occur coexistingly. So the presence of posterior acoustic enhancement helps in differentiating primary thyroid lymphoma from Hashimoto's thyroiditis. But again, sometimes severe Hashimoto's thyroiditis can present with posterior acoustic enhancement. The clinical finding helps us in differentiating between these two entities. For example, PTL patients present with pressure symptoms, rapid increase in size, and it is usually a painless process. Whereas Hashimoto's thyroiditis usually don't have pressure symptoms or rapid increase in size. Rapid increases when the size increases within a short period of 3 months. And whenever we suspect a primary thyroid lymphoma, we usually go for a biopsy instead of a FNEC because lymphomas need further IHC characterization. The other differential diagnosis for primary thyroid lymphoma can be papillary carcinoma of thyroid with lymph nodal metastasis, which usually presents as a focal lesion with lymph nodal metastasis. Primary thyroid lymphoma, especially of the diffuse type, it is usually the entire thyroid gland is enlarged. So a biopsy was done in this patient from the lymph node and the thyroid. Here we are able to see the course of tissues which were taken. There was a lymphoid tissue which was seen both in the lymph nodal sample as well as in the thyroid sample with the colloid of the thyroid, and there was atypical cells of the lymphoid, atypical morphology of the lymphoid cells, which was suggestive of a lymphoproliferative disorder. So the take home message is, if there is a diffuse enlargement, markedly hypoechoic ecotexture of the thyroid, and if there is rapid enlargement with pressure symptoms and absence of calcification with cervical lymphadenopathy, the possibility of primary thyroid lymphoma has to be raised. When there is posterior acoustic enhancement, that helps as a useful criteria in differentiating this from Hashimoto's thyroiditis. These are some of the references. These two articles were especially very useful for identifying the sonographic appearance of primary thyroid lymphoma. Thank you.